Welcome. This is a very special evening. We have almost 4,000 people signed up, and it's a combination of colleagues, practitioners, and regular folk. So we have an esteemed panel of doctors, and we're going to try and speak to the global presence of all of you today. I'll be introducing them in just a moment. You know, your body has an internet system. One cell tells another cell what to do, and that's how things get done. And what's so special about hormones is that they can actually dive into your archival information from your family history. They can get into genes, and they can signal genes to tell your cells what to do to keep you healthy. Illness and aging are somewhat freezing up of this email. So if you think of your hormones as running the internet system of your body, and illness and aging as somewhat the freezing of your internet system, which you all know what happens when your computer freezes up, you can't get any work done. It makes common sense that if we had the capability of getting hormone replacement, we might want to consider this. But hormones are in the rabbit hole today. And I knew we needed a narrative like this when I had the opportunity just a month and a half to 2 months ago to speak at the largest anti-aging longevity conference put on by A4M in Vegas. There was a sea of 5,500 young physicians sitting there eagerly. There were 150 speakers. About half the speakers said, with full bravado, hormones are one of the best anti-aging tools we have, and they help prevent cancer. The other half of the speakers said with exactly the same bravado, hormones accelerate aging and they drive cancer. The thought right now is that hormones drive cancer so much that in med schools, osteopathic schools, naturopathic schools, women who live a third to a half of their lives in menopause, these doctors aren't being trained how to manage menopausal healthcare with hormone replacement because hormones have been so driven into the ground. And the consensus, for some misinterpretive reason, is that estrogen drives breast cancer. So I felt we needed a narrative like this. I called up my esteemed colleagues. Everybody here has an average of 30 to 40 years in practice prescribing hormones. Almost none of us have seen an uptick in breast cancer cases. I went and asked most of these esteemed colleagues, how many cases have you seen with an average of 3 decades to 4 decades under your belt of prescribing bioidentical hormone replacement? And they usually say 2 to 3 women. And most of those women do really well. They have less aggressive cancers, and they tend to die less if they do have cancer. So how did this misunderstanding and pig pen dark cloud over estrogen unfold? So I want to go back for a few minutes. I'm not going to take too long before I invite our esteemed colleagues to take the dais. And I love to say that word, so I finally got to fit that one in. How did this begin? Because in Britain in the 1950s, estrogen was queen. And estrogen replacement therapy became so popular. The message was if you took estrogen replacement, you could be feminine forever. It was a great anti-aging tool. And it was so heart protective that doctors for decades wrote scripts for women after you had a heart attack, after you had a stent put in, if you had congestive heart failure. Hormones were given to cardiac patients, high-risk cardiac patients, and they did really well with it. So we are an aging nation. In fact, it's prophesized that by 2030, the majority of the United States will be over 65 years old. Because of that, we don't want to topple Medicare, and we thought that hormones were the best thing since sliced bread. So our own NIH started a huge set of studies called the Women's Health Initiative. So this was 40 different prestigious institutions, like Harvard was one of them, under the auspices of the NIH, and they started a variety of studies, and they decided that we're going to take a look at how we can keep aging women well. Women live longer than men, and we know that men die earlier, women live longer, and we don't want to topple Medicare. And the first set of test that they wanted to do was prove that hormones were the best anti-aging tool that we could have. So they took a look at estrogen only for women who didn't have a uterus, and they took a look at women who did have a uterus. They added a synthetic version of a progesterone called progestin, and we're going to have Dr. Brownstein and Dr. Petersen talk soon extensively about the differences between those. And they started to track women thinking that we were going to prove that hormones were fabulous. Within a few years, they prematurely stopped the combo arm that had the synthetic progestins added to it because they saw an uptick in breast cancer patients, which, by the way, didn't really, as they watched these studies and the women who took part in them over time, that uptick didn't necessarily keep going on. But they stopped those studies, and we are a very litigious society. Doctors got sued, Wyeth got sued, everybody in the United States stopped writing scripts for hormones in the consciousness of America, equating estrogen with breast cancer. Now, mind you, the estrogen only arm, which was tracked within a few months, then 5 months, then a year, then 3 years, then 12 years, 17 years, and 20 years. It was tracked multiple times over a 2-decade period to see if women who took on the average of 5 years of estrogen, if in fact they ever did get an increased risk of breast cancer. And in December 2019, right, I'm in Austin, Texas presently, and every year in San Antonio, Texas, there's a breast cancer symposium where researchers from all over the world come and share their data. The original authors of the Women's Health Initiative in 2019 gave the 20-year reanalysis of the Women's Health Initiative, and they said, we looked at all of these stages of the estrogen-only arm, and at every single point through the tincture of time, women who were on estrogen for an average of 5 years had less breast cancer. And if they did get breast cancer, they had a better player. It was less aggressive. They tend to die less. And in the final reanalysis at that 20-year mark, where all the authors put their names to it, they said if women were on estrogen replacement for an average of 5 years, they had a decreased incidence of getting breast cancer in the first place by 23%. And if you happen to have been on estrogen replacement and you did get breast cancer, and then your risk of dying from it, which is called fatality incidence, was reduced by 44%. Nothing has ever been so breast protective. But at that point, we'd stopped teaching menopausal medicine using hormones in med school, osteopathic school, and even in naturopathic school, while Europe never stopped writing scripts. They mostly write scripts for natural hormones, and they're socialized countries who really track what each patient costs the country. They now offer, in many of those socialized countries, they offer a woman hormone replacement when she starts getting later perimenopause, early menopause for free, because they've tracked and seen that that woman costs the country less, just like our Women's Health Initiative was all about trying to cost the country less. But why then do some doctors say, hey, estrogen drives breast cancer, and others say don't? Well, the medicine is a hiccuping kind of deal. It goes up and down and in and out, and it's only over the tincture of time that you look at trends. For example, like aspirin. The American Heart Association used to say everybody should take aspirin to avoid getting heart attack or stroke. Now they say it causes so many silent bleeds, you should only take it if you've had heart attack and stroke. Things in medicine change all of the time. But somehow we've gotten really stuck with this estrogen issue. There's some studies that say, yes, estrogen does uptick an increased risk of breast cancer, even a bit after you go off of it. But the majority of these studies, not all, the majority are estrogen added to synthetic progestins. In fact, one of the largest studies ever run by Agnes Fournier, it was called the French Cohort Study, E3N EPIC Cohort Study. They looked at 80,000 women over 10 years and women on estrogen and progestins. It echoes exactly what happened with the Women's Health Initiative, which has been misinterpreted. Women on estrogen and synthetic progestins had an increased incidence by 69% of breast cancer. But if they mixed the estrogen with natural progesterone, bioidentical progesterone, looking exactly like our own molecule, there was never an increased risk. So there's some studies that say that estrogen upticks, but the majority of those studies, not all, it depends on what the estrogen was mixed with and how it was taken. But there's many more studies. In fact, even the Women's Health Initiative that literally say if a woman's on estrogen without synthetic progestins, her breasts are better off and her life is better off. What we do know is these synthetic versions of hormones, and we tried to invite some of the naysayers of the way that we're talking, and they didn't want to come on. So there's somewhat of a consensus with our esteemed guest today. But the one thing that's maddening to me is that oral contraceptives are the number one way that hormones are sold globally. 300 million women around the world are on oral contraceptives, which are synthetic estrogen and synthetic progestins. 11 million women in the United States are on them. There is no study that doesn't say birth control pills do not increase the risk of breast cancer. Every study says that. And this risk continues. It has a duration even after you go off. And a month and a half, 2 months ago, they were made available OTC, over the counter. So we have this odd reality, this crazy kaleidoscopic reality where synthetic hormones that are really the main bugaboo in some of our opinions, and I'm going to want to hear from our other colleagues, are the issue, while we are denying older women hormones that there's more data saying that they're heart, health, and breast protective, yet at the same time we are handing out like M&Ms scripts for birth control pills that don't have any one study that says it does not increase the risk of breast cancer. So here we are with a need for a discussion so that we can let providers not be so frightened based on misinterpretation of data, and for patients to hear this discussion so they can have peace of mind and make some decisions themselves. So we have today with us to have and continue and dive deeper into this conversation. We've got Dr. David Brownstein. He says we're two peas in a pod. We both graduated from the University of Michigan, and we adore each other. And he's going to take the microphone next. We have Dr. David Rosensweet, who has been in the field for 30 plus years. And he was one of my breast cancer doctors 30 years ago. And I have been on bioidentical hormones for 28 years. And I just turned 75. We have Carol Petersen, who's been a doctor of compounding pharmaceutical science and has worked with one of the more famous compounding, the Women's International Pharmacy that was then bought up by Belmar Laboratories, where in fact I get my low dose naltrexone every month. So I adore Belmar. And then we have Dr. Anna DeRosa, who is this incredible physician with this massive understanding of hormones that when I had her on my show, I learned so many things that I've since added to my tool bag. I'm grateful to have you all here. I think that was a good introduction to what we want to do is really address estrogen safe or not. And I'm going to let Dr. Brownstein take it away.
Well, thanks for having me, Lindsey. I'm honored to be here with my friends and colleagues. And I told you I would start off by talking about the University of Michigan National Championship Wolverines. Put on my sweatshirt, which I did wear to work today. And I am only wearing Michigan clothes to work till April 1st in honor of the defending national champions. Now that that's out of the way. You mentioned at the in your monologue that at the meeting you were at, half the doctors were saying hormones are promoting aging and promoting the increased rates of cancer. Well, if it's promoting aging, I haven't seen that in 18 to 20-year-olds. When we were in college, and if you go visit college, and if it's promoting cancer, I don't see that in those 18 to 22-year-olds either. Cancers, my experience is that men who are getting prostate cancer have very low testosterone levels, and women who are getting breast cancer have very altered hormone levels as well. Now, Lindsey and I, we talk all the time, and when we were hashing this out, the idea of doing this, we were sharing some of the articles saying that estrogen increases breast cancer risk, and we kept saying to each other, it's not our experience in our practice. And then Carol and the rest of the panel will talk about their experience. I'm sure that's not been their experience as well. And I don't think that hormones should be given as sole therapy. I think they should be given in combination in a holistic treatment regimen, as part of a holistic treatment regimen. I think part of the problems with hormones is if you just give them alone without any support for the rest of the body, that perhaps you're missing some things, and people can't detoxify, or their liver is toxified or something like that. Hormones are going to last a little bit longer and perhaps cause problems. I don't do that. I give it as part of a holistic treatment regimen. And you just a couple things about the Women's Health Initiative. You mentioned the Women's Health Initiative with estrogen, the estrogen only arm, not showing that increased rates of breast cancer or heart disease. The Women's Health Initiative was really set up for two major questions. Was to answer the question, do hormones prevent heart disease? Because women were promised this from the beginning of synthetic hormone therapy, that if you take these, you're not going to get heart disease, and it's safe. You're not going to get breast cancer. Well, the Women's Health Initiative lied about that, because the progestin arm, the Premarin progestin arm, showed that there was an increased rate of heart disease and there was an increased rate of breast cancer, and that's why it was stopped early. However, the estrogen-only arm, which was not natural estrogen, this is not bioidentical natural estrogen, this was horse estrogen, Premarin, which is much stronger, much larger molecule, and even that synthetic hormone to human females did not show an increased rate of breast cancer or heart disease. Now, what happened, I remember when that study came out, and I remember the explosion of negative comments about hormone replacement therapy. And I looked at it, and as soon as I saw that Provera was in the one arm, I'm like, well, that's why heart disease went up, and that's why breast cancer went up. And then shortly, I can't remember if they were released together or slightly separately, but when the estrogen only arm came out, you saw the difference immediately. I didn't even know what the furor was back then. And as you mentioned, over the next 20 years of releasing data from that study, the same numbers have held true. So I can't quite understand why it's still getting the negative press that it's getting. It's a very positive article for using hormone replacement therapy if you use the right hormones.
And David, to even parlay off of that, when you looked at the PEPI trial that went off before that in cardiovascular disease, it showed the distinct difference between prometrium and a micronized progesterone versus the progestin.
You were totally right. That was in the 90s. And I remember I was just starting to use these hormones when that PEPI study came out. And I was asked to do a debate with a gynecologist in a newsletter I was employed by a hospital for a short period of time where I realized I'm the worst employed doctor ever. And we did a commentary back and forth on that PEPI study. I agree with you on the PEPI study was pretty easy to read, that bioidentical progesterone was safe and Provera wasn't. And I asked the question, I don't know why it's not removed by the FDA, and where are they stepping in, which the Women's Health Initiative verified, and so many other studies verified after that.
But yet you hear from doctors, the Women's Health Initiative told us that estrogen causes breast cancer. That's the mantra.
Yeah. Synthetic progestins have been shown in vitro to increase estrogen-stimulated breast cell mitotic activity and proliferation, which increases the risk of breast cancer. Bioidentical progesterone has the opposite effect in vitro in breast tissue, inhibiting estrogen-stimulated breast, epithelial cells. And that has been proven over and over and over. And again, I would encourage, the listeners to, use it as part of a holistic treatment regimen of vitamins and minerals and herbs, and cleaning up the diet and drinking water and exercise and making sure the liver is optimized. All this stuff helps. And, one of the things that I want to talk about, and if I want to talk about it now or, later in this, is, the purpose of iodine. Iodine deficiency is rampant across the United States. My partners and I have been checking levels for close to 25 years. And over 97% of people are low on iodine, most of them dramatically low on iodine. The only ones that aren't low on iodine back in the day were the ones who read my book and started taking iodine. Everyone else was. Now, I live in an iodine deficient area of the world, in Michigan, around the Great Lakes, where the national champions reside. And our soil is known as one of the lowest iodine levels of the world. And, we're in the Goiter Belt. But through poor farming techniques and our food supply that nutrient levels have declined, iodine deficiency is rampant across the country. Because I hear from my friends and colleagues who check iodine levels, they're finding the same thing. And iodine has multiple mechanisms to help estrogen metabolism in the body. And for those studies that show that estrogen increases breast cancer risk, which I agree with Lindsey, are much fewer than the ones that show estrogen does not increase breast cancer risk. I would say that the researchers should be looking at the iodine's effect with it. And we know that iodine decreases the inhibition of BRCA1. Women are being checked for BRCA deficient,
polymorphisms. Glitches, genetic glitches.
Yes, and then getting breast surgery and ovarian surgery and uterine surgery, if they have these inhibitions. So iodine perhaps could help prevent that inhibition of BRCA1. It's been shown that estrogen-dependent breast cancer is greater than twofold as sensitive to the apoptotic effects of iodine as compared to estrogen-negative cancers, estrogen receptor-negative cancers. Been shown that iodine increases phase 1 estrogen metabolizing enzymes, and that 2-hydroxyestradiol can be converted into 2-MeO, which has anti-proliferative effects. And for those that don't know, we probably have the world's expert on 2-MeO here right now. It's Lindsey, who taught me about 2-MeO, 2-methoxyestradiol, and has multiple anti-cancer effects to it. And Lindsey, if you want to mention a few words about that, go ahead.
Well, Mother Nature never does anything without a reason. So estrogen does cause growth signals, but estrogen, if it's the oldest hormone on the planet, so it signals a receptor, which is like a satellite dish, and it has more receptors than and more satellite dishes than any other hormone. And its second satellite dish signals anti-cancer. In fact, Yanaki Gustafsson, who I worked with at Tulane, who discovered the second receptor, he said when estrogen is signaled at that second receptor, it basically acts like our own natural anti-cancer mechanism. We've got that, and estriol helps signal that. Iodine helps signal that. And then as estrogen is metabolized through the body, if you can methylate the final metabolite of estrogen, 2-methoxyestradiol, or the nickname 2-MeO, acts like a chemotherapeutic drug. So you have two natural anti-cancer versions of estrogen metabolites in your body that iodine helps produce, a good diet helps produce, and also taking iodine supplementation while you're on estrogen replacement helps keep you safer. But why is it that so many people are frightened of iodine today? And you even hear some very famous speakers say never take it at all.
Well, there's a lot of medical iodophobia around the country, and I feel for those people. Because they just don't know the literature. And, it's the same thing. It's the same argument you gave at the A4M conference. Half the speakers were saying you should use hormones, and the other half were saying it causes cancer and, aging. And it's the same thing with iodine. Let me tell you, if iodine didn't work, or iodine was causing all these effects and, autoimmune thyroid disease and whatever else that the people are saying, I don't know how I'm in business. I've been using it for about 25 years. The vast majority of my patients are on it. I started using iodine in relation to thyroid problems first before I learned about the breast, but it's very similar in the tissue's response to it. We know that iodine deficiency results in disrupted architecture and atypia in the thyroid and the breasts. In the thyroid, you get goiter and nodules and cysts. In the breast, you get cysts and nodules and eventually breast cancer in iodine deficiency. Bernard Eskin, probably 30 years ago now, did studies showing that fibrocystic breast disease took up twofold more iodine than normal breasts if they gave women who were iodine deficient iodine, showing that the altered architecture and fibrocystic breasts were more iodine deficient. We know that if iodine is given in an over 100 times the RDA amount, which now we're looking at milligram amounts since the RDA is 150 micrograms, that you can produce iodinated lipids in the thyroid gland and the breast tissue. And the most prominent iodinated lipid is delta iodolactone. And delta iodolactone has been shown to prevent the alteration of the architecture of these tissues. And you need 100 times the RDA for iodine to do that. And if there's no delta iodolactone, the architecture of the thyroid has been shown to be worsened when estrogen is added to this situation. So it needs iodine. I mean, hormones need to be done in a milieu, with all the other hormones, getting everything balanced at once, with diet, with detox. And, I think iodine should be a prominent thing with this.
David, what dosages are you using to treat, for example, women with fibrocystic breast disease?
So there's a lot of research out of the old Soviet Union that iodine, and over the years, iodine has been shown as the most successful and the most used single treatment for preventing and reversing fibrocystic breast disease. It's estimated that over 80% of women in the U.S. have fibrocystic breast disease. And I can tell you over 80% of women are iodine deficient if they're not taking iodine. So the doses, unfortunately, we are more iodine deficient now than our predecessors were. And that's because of our exposure to toxic halides, bromide and fluoride.
And sodas, a lot of sodas and pastries and things. Right.
Bromine's in mountain, it's in sodas, and it's also as a brominated flour in pastries and bread products, as Lindsey said. And bromine's also used as a fire retardant in mattresses and chairs and computers and iPhones, and it's all over the place. So we become over-brominated, over-fluoridated, and under-iodinated, which has made this iodine deficiency problem worse. So the doses I use are, and what I found with my mentor in iodine, Dr. Guy Abraham, who developed the iodine loading test, that I usually have most of my patients on about 25 milligrams a day. If they have problems with their glandular tissue, thyroid, ovaries, uterus, breast, prostate, pancreas, which all concentrate iodine against a gradient, and all iodine works in these tissues to keep to prevent abnormal architecture or keep normal architecture of these tissues. If they have problems with these tissues, I usually will start at 25 milligrams. And if they have cancer, those tissues go up between 50 and 100, or sometimes even more than that.
Thank you so much. There have been lots of studies that about 3 milligrams in a typical small A-size cup, the size of the cup matters, how much breast tissue you have matters, but it goes from 3 milligrams all the way up to almost 100 milligrams. And we now have a lot of doctors lecturing saying you shouldn't go above a few micrograms. So there's a lot of disparaging conversations, which is why it's wonderful for all of you out there to get in on these conversations here. So Dr. Rosensweet, I first met you when I had breast cancer, and here we are in the hormone space together. And I would love to hear your comments of what you would like to add.
Well, to begin with, I want to go back to the Women's Health Initiative, because I've never seen an event like this in my whole career that injured so many people so profoundly. And when I read that in 2002, I had already been treating women for over 10 years, and I was alarmed until I read the study. And what I saw immediately, that there was a reduction in breast cancer with the use of horse urine-derived estrogen, reduction in breast cancer rates. The study had many flaws in it. And there was a comment that actually the Prempro, the combination of Premarin with the medroxyprogesterone acetate, it had a 1.26 increased relative risk for breast cancer, which was, in the study, statistically insignificant. That didn't matter. That in science, we know that if the word statistically insignificant is used, it means don't draw any conclusions, folks. We don't have the answer yet. And they followed these women, and like you said, and then the original study committee reported in the original journal in 2017 that after 18 years of follow-up, there was no increased risk of breast cancer, heart attack, and stroke. That's as much as they were willing to admit.
How come the doctors all say that there is? Where's the disconnect here?
The disconnect is, who can explain how such a misogynistic event can take place on the planet Earth?
Thank you. Misogynistic answers it.
For false information. There was 18 million women, and 40% of the women in menopause in 2002 were on Premarin or Prempro, and it went down to less than 2 million. And the consequences of that were really, really disastrous. But
now women need a whole conveyor belt of medications to try and do what the hormones might do. Okay,
What I'd like to do, though, is give you the science, because I've cared about this for 30 years. And what's the bottom line in treating women in menopause? It's prevent breast cancer and don't cause breast cancer. So I've studied this deeply, and there happens to be a world expert on risk. And his name is Avram Blooming. He's an oncologist. And his book, Estrogen Matters, for those of you who are concerned, really dives into the science of this and lists all the studies. You can have a studies war, saying one side and saying the other, but there is conclusions that can be drawn. And here's the conclusions. We are all at risk for thousands of diagnoses. And a lot of them are not good. And we're all at risk for hundreds of cancers. And as a male, I have an increased relative risk, which wasn't always true, for prostate cancer. And there's reasons for these. There's reasons for cancer. And women have an increased relative risk for developing breast cancer. Given that we're all at risk, here's the science. Women who are treated with hormones, and I'm even talking about Premarin and Prempro, are at less risk for breast cancer, heart attack, and stroke than women who are not treated with hormones.
Let that sink in.
Women who have been treated, who have developed breast cancer and have had that breast cancer properly treated, they happen to be at increased relative risk for recurrence than a woman has for developing a cancer brand new. But the women who've had that breast cancer properly treated are at less risk for recurrence if they're treated with hormones than if they are not. This is the science. Premarin, Prempro. I've never written a prescription for Premarin or Prempro in my whole life because there's such wonderful alternatives. However, none of these have proven to cause cancer. In fact, if you dive into the medical literature, you will conclude what Dr. Blooming has concluded, and what anyone who really wants to pursue it is hormones for women reduce the risk for breast cancer, heart attack, and stroke.
So, I just heard a very famous speaker say, well, there's the HERS study, the ERA study. They tell us that this estrogen deficiency theory is no longer strong. But when you go back and look at those studies, those are on older women who already had heart disease to see if hormones might slow down the progression of heart disease. And what did they use? They used synthetic progestin. So we constantly hear accusations against the veracity and safety of hormones. But when you then dive into the literature, it doesn't hold up, but it's taken over our med school professors. It's taken over the clinical trenches. And most women that ask their physicians, am I a candidate for hormone replacement, are told, I don't believe in hormones. They're not really safe. Your aunt has a clotting genetic disorder, factor V Leiden. I wouldn't do it. So what might people that are listening do because of this disconnect? This is the issue.
Well, and I think a lot of the problem is that medicine has become so siloed, and women are broken into body parts, and they want to really look at us in isolation. When you really start to look at the body as a whole, and to Dr. Brownstein's point, is that it takes resetting the whole system and not just looking at one part. And if you're concerned about bleeding, and then the gynecologist is going to put you on progestin and to help prevent the bleeding, but God forbid that they don't look at testosterone or thyroid or how the estrogen can affect, or that impact of putting someone on a progestin that lowers estrogen or lowers testosterone, and its impact on every other thing, or their mood, or the insulin resistance, or all the various other things. Until we start looking at people as whole beings and not isolating systems, nobody's ever going to get it right. And unfortunately, as we all painfully know, that there's a great deal of gender bias in medicine, and the fear of breast cancer has become so irrational that, to Dr. Rosensweet's point, I mean, the risk of breast cancer is greater if you're a flight attendant, have vitamin D deficiency, if you drink wine, you're obese, you're sedentary, than ever going on even the worst progestin or even the synthetic estrogens. And let's not forget, too, to add to the point, when you looked at the WHI, the estrogen alone arm at 18 years showed an overall decrease of breast cancer by 45%. And even with the awful progestin Provera, which we all know increases inflammation in the body, when you actually looked at that study, it was only the decrease of incidence in breast cancer in the patients who had already been on hormones that went into the placebo arm, that it was really this mysterious thing. We don't know why the trends dropped down, but the actual treatment group never increased incidence. And it created this false sense that there potentially was an issue that never was. And it was only 25% of the patients in that arm. So even the bad progestin is being completely misunderstood as well. And it's much more complex. And if you don't take the time to study it like we do in and out, you're not going to understand it. And you propagate the myth because it's easier.
In 2018, Hudis wrote this paper where he said, look, the whole methodology was wrong.
Yeah.
In the combo arm, we forgot to ask women in the control group who were on placebo, did you ever take estrogen historically? Because now we know estrogen actually protects breasts. So they forgot to ask women that. So the incidence of breast cancer actually, what looked like it was lower in that arm because they had more women whose breast tissue was protected. So the women in the experimental arm looked like it was higher. There's all these ways that these studies have really been wrong, but yet at the same time in med school, osteopathic school, naturopathic school, they are dissing hormones. They are saying estrogen with such conviction, when patients hear a doctor speak with conviction, estrogen drives cancer. And so many women are being denied. And that's why I wanted to have this conversation. I think it's so important. So what might we do besides having conversations like this to pass this word forward? That's why I wrote the book, Safe Hormones, Smart Women, which was completely a reanalysis of the Women's Health Initiative. But what else might we do to help women gain access to quality hormone prescriptions?
Keep talking.
Yeah, I think
Spreading the
it's
word.
all, and I'm sure you've all seen this as well. It's really going to be very, very slow to change on the medical side. And to Dr. Rosensweet's point earlier, we have done more harm with this one study that it's actually malpractice against JAMA and whoever else published all that information incorrectly to stimulate fear. And it's going to still continue. It's been 20 years and we're still having this debate. And the data has been out there in hordes of information that goes against what the original media message. But the only thing that I'm finding a little bit gratifying and also hopeful in this scenario is that our patients are really starting to drive this because they're now seeking alternative answers away from the conventional thinking practitioners because they know they don't feel good. They're starting to question authoritative patriarchal medical healthcare and saying there's got to be something better, and they're coming to folks like us. So I think the patients are going to be ultimately the voice of reason when this all comes said and done, and then the medical profession will follow. But that's just my 2 cents.
So I've got a question I want to pose, and if Dr. Carroll wants to talk about this or whoever wants to answer this, we know that testosterone is breast protective. Maleness protects femaleness. So testosterone goes from testosterone to its next metabolite, dehydrotestosterone, to its third metabolite, 3-beta-diol. And when it signals the breast, it fights cancer. And we know that one of the reasons that birth control pills increase the risk of breast cancer is they lower testosterone. Yet at A4M, where I was just lecturing, they say never recommend testosterone replacement in this tapestry of hormone replacement. So can you talk about that, about testosterone replacement being added to your other hormone therapies to keep them safer, or your opinion on that?
I have very, very, very strong opinions about this. And one of the things that incenses me the most that we, as to the other points, is that we hand out birth control pills in droves to young women without understanding the implications it has on its body. And when you look at birth control pills, how they work is they essentially shut the ovary down from producing estrogen, from producing progesterone in the second half of the cycle, but also very importantly, 95% of our testosterone production, which yes, women make a boatload of testosterone and it's actually our most abundant hormone. And think about what testosterone does. Everything it does for a man, it does for a woman. It prevents insulin resistance, the prediabetes, diabetes, the heart disease that follows that. It prevents or it causes mood disorders, panic, anxiety, depression in our young women. It causes weight gain. It causes bone loss. It causes a whole host of things. And yet we don't even discuss it.
To be insufficient in testosterone.
And to be insufficient, correct. And the other thing is that testosterone is breast protective. It decreases the inflammation in the breast. It decreases proliferation of those bad breast cells. It causes cells that become bad to die faster. And when you actually look back at the data, we used to use testosterone to treat breast cancers back in the 30s, and throughout history, it's been very, very positive toward breast. And there's wonderful research. Dr. Becky Glacier, who's one of the most leading experts in this area, who has shown that testosterone pellets will reduce a woman's risk of developing breast cancer. And oh, by the way, if you already have breast cancer, if you go on testosterone with an estrogen blocker, because breast cells, when they're in cancerous states, increase an enzyme that can potentially become problematic, that they actually have a decrease in recurrence rates. Testosterone is one of the best things we can do for a woman's breast, but we don't even talk about it from a breast standpoint, let alone all the other benefits that it can do for a patient. And it's really a horrible thing that we do and a disservice for our female patients.
I am only willing to prescribe testosterone to 100% of my women patients because
Oh, me too. I think every female should have testosterone.
and like you said, Angela, I mean, women produce twice as much testosterone as they do their most powerful estrogen, estradiol. And when you look at the 70s and 80s and 90s decades, and you start asking yourself, why is there such an epidemic of canes, walkers, wheelchairs, assisted living, nursing homes? And elderly people, for the most part, do not like that transition from the home to the nursing home. They're willing to do it, and God bless nursing homes. But 80% of folks who are in the nursing homes are in there because of hormonal deficiency. And leading the pack in women is deficiency in testosterone, leading to sarcopenia, loss of muscles. Women fall, fracture a hip.
Yep. You go, girl.
Testosterone is a phenomenal hormone, and every single woman I've ever tested by 3 years with no period is super low in testosterone. And these days, different than when I was younger, it seems like 3/4 of the women going into the perimenopause are already deficient in testosterone.
Because they've been on birth
perimenopause.
control pills, and birth control pills lower testosterone. It's one of the reasons birth control pills elevate the risk of breast cancer. It has a number of mechanisms, but one of the main ones is maleness is breast protective, and birth control pills lower the male hormones. So it's so crazy. Now they're available OTC, but yet we're telling women estrogen's dangerous for you and don't go on hormones. It's all backward. But they say it with such conviction and such arrogance and incredible marketing that the average physician and the average patient is mixed up. This conversation is going to go viral around the globe, as well it should, so that we can help allay a lot of women's fears and help them age more safely.
So if you want to think about something else that just make you a little bit crazy, and just think about this, when patients always ask me, and actually other physicians, so why don't men have birth control pills available to them? Well, they were actually studied, and what they put in those birth control pills were progestin, a synthetic progestin, which did exactly what birth control pills do in women. It shut down their testicles from functioning, which lowered their sperm. But also, just like it did in women, it lowers their testosterone levels. Well, here's the interesting thing. All of the men dropped out of the study because they refused to deal with the side effects of the low testosterone, the erectile dysfunction, the libido, the migraine headaches, the cognition, you name it. But yet women get put on them all the time, and we're expected to deal with the consequences of it.
We're told that you don't have the issues, side effects of the birth control pills. Now you need anti-anxiety meds for your anxiety, and now you need migraine meds for the migraines that it gives you, and you need more conveyor belt medications. Now you're a patient with learned helplessness. You're on more meds because of these meds rather than doing the root cause issue, which is this tapestry of natural basic answers to get you safer.
And don't forget, one of the most prescribed conventional medications are statin drugs. And statin drugs poison an enzyme HMG-CoA reductase, which lowers cholesterol levels, so it works as advertised. But below cholesterol, if you look at the adrenal and sex hormone pathway, it's cholesterol is needed to make all the hormones, all the sex hormones. And so we put people on these statin drugs, and their testosterone drops off, DHEA drops off, it all drops off, and people feel lousy, and they're told it's great because they have these super low cholesterol levels. Well, then they can't protect their nerve tissue, they can't protect, cholesterol is an anti-inflammatory agent, and it's just, it is maddening out there. And Yeah, I'm just giving a little plug for those who identify as male out there. We're screwed too. They don't prescribe testosterone
Guys
and
are-
you say it causes or worsens prostate cancer. That's not true. And men get just as, and women are more screwed than men. I'll give you that, but men get screwed too here. But anyways, that's a
Carol,
I-
would
I
you,
have
Carol,
to
would
jump
you?
in here.
Yeah, great.
Please,
Thanks.
Carol, jump
I-
in.
I
Please
was
do.
I was hoping to
I-
hear about progesterone and its
Yes,
effect
so
on anxiety, for example.
Oh my gosh. So I have to come in here and really stress that progesterone trumps both estrogen and testosterone. If you talk about the quantities, even in the follicular phase and the menstrual cycle, and I just heard Peter Attia in an old podcast says it's a nothing burger. Progesterone does
Etienne is from
nothing. He's got so much just information. It just is nuts. But okay, so what's the normal progesterone level in follicular phase? 1 to 3 nanograms per milliliter is pretty normal. So if we translate that into the units that you'll find the estradiol in, which is in picograms. So maybe in the follicular phase, you're going to get up to 300, maybe 500 in picograms of estradiol. What are you going to see in progesterone when you change that 1 to 3 nanograms? It's 1,000 to 3,000. How dare you say progesterone is doing nothing? So we have all these menstrual cycle charts, and sometimes they leave off the units and they put progesterone down as flatlining and not really appearing till after ovulation, when the corpus luteum produces even more. Now we're talking up to maybe 20,000. It's so significant and being so ignored. I'm beginning to think there's a progesterone conspiracy. So Lindsey and David sent me this article from the Lancet, was looking a meta-analysis, huge number of women were looked at. There was some sort of collaboration, and it was so hard to make heads or tails. I'd like to caution everybody to be really careful. We are trying in this group, and in functional medicine, we're trying to be very clear when we're talking about progesterone or progestin, synthetic analogs. We need to be just as careful with estrogen. We shouldn't just say estrogen, we should say exactly what we're talking about. If we're talking about Premarin, conjugated estrogen, if we're talking about estradiol, bioidentical, we should say so. So I said to Lindsey, I said that I can't get my head around this Lancet article. Where's the progesterone? Where do they compare women taking progesterone? So you have hundreds of thousands of women that they're trying to compile data, and where are the progesterone users? And I just found somebody wrote a letter, British Medical Journal. His name was Peter Lewis. He's from Australia. He's talking about this Lancet article. He goes, in page 45 of the appendix, you'll find progesterone. And I asked Lindsey, where was the appendix that they were talking about in this article? It didn't make it available to us. So there it is, hidden. The relative risk of, now I am going to say generic estrogen because they did, and I can't say which, but the progesterone added to the estrogens, you're down to 0.91 relative risk for breast cancer. So now that means you're better off with progesterone than in no hormones at all. So wow, what's wrong with that? Progesterone is such an important balancer of many actions of hormones, and we have this thing, we have to be working through receptors, estrogen receptors and progesterone receptors. There's paracrine, many other mechanisms of action for progesterone that we hardly have an inch of understanding with this. So I also found this very interesting statistic. What happened in 1896 Sir George Thomas Breton did an oophorectomy, removed the ovaries from a woman with metastatic breast cancer. And this woman lived. So that's why from this time forward, this was the first, 1896, this woman, if you go and your doctor says you have breast cancer, you have estrogen receptor positive, you have progesterone receptor positive, that practitioner is going to say to you, no hormones, we have to ablate all the hormones. Just today I spoke with a client. Guess what she's doing? She's sneaking in hormones. She had a diagnosis of breast cancer. She's gone down to Mexico. She had cryotherapy. She's doing other alternative things. What is she using also? She's using her estradiol. She's using testosterone. She's using progesterone. And this woman is thriving. She said, I feel fantastic. Who among us who take conventional treatments for breast cancer is thriving in that manner? I'd also like to point out a little bit about the history of Premarin. So I worked for Women's International Pharmacy for 27 years, and so much I learned along the way from many, many teachers. But one day I'm working, and this gentleman is on the telephone, and he tells me his wife is on PremPro, the Exact Women's Health Initiative products, and not doing very well at all. But he happened to be a Wyeth trainer, training the salespeople to teach doctors to use PremPro and Premarin in their practice. So what's he tell me? He gave me a history of where'd we get Premarin from? Why in the world do we use such a thing? As David rightfully pointed out, this is a product based on a horse, a massive animal. So we have many more hormones. They said, this trainer said, we started out using female pregnant urine. And this sort of aligns with Dr. Jonathan Wright, going back to David Needham's work about the Chinese.
Right.
We're collecting young men and young women's urine and drying it up, and they had bioidentical hormone therapy. What's wrong with pregnant women's urine? That would probably be okay. Maybe you have to adjust a few things, but we wouldn't be damaged with foreign hormones. And then he said, then they went to baboons because it got to be too expensive. And then finally they settled on horses, which they do have a lot of urine, which is an advantage. So it's a completely money economic decision by a drug company, not for good therapy as far as using estrogens, but only a financial decision. So why is that financial decision so prevalent? It's because they go out there and go to various doctors' offices with a horde of salespeople trained to convince you this is somehow better than what your body makes itself, that Premarin would be a delightful choice. Premarin, actually, I saw a recent article. They've identified 60 of the molecules in Premarin that are cholesterol-like. These hormones all have a 4-ring structure. 60 of these. There's a certain percentage that are estrogenic. There's a certain percentage that are progesterone-like, and there's a certain percentage that are testosterone-like. So how can we make any sense of anything when we throw this whole pot of different things at the human body? How do you sort out what you learn for that? The Women's Health Initiative really made a big mistake in not using human hormones. Now, they would argue that they're using it because that's what people were using it. And Premarin was successfully marketed. It was a top-selling drug in the United States for many, many, many years. Now, progesterone has a delightful balancing effect on estradiol. And I realized not too long ago, I really don't know. And I've done some searching, not really intense. How does progesterone balance estrogen? Is it mediated through receptors? Is it some other thing? I think we're even vague on that, but nonetheless, it does. But one of my major concerns is what happens with the dose of progesterone. I've already made a case about how abundant it should be in the human female body. And if we're not restoring this abundance of progesterone, we might not get the same effect. And there is some in the literature where progesterone can be proliferative, and it's something that you'd like to avoid with a existing cancer, but it will be in the small doses of progesterone. An underdosed woman can experience and does experience with great frequencies a intensifying proliferative effect, maybe mediated through estrogen. We're not too clear. I love one Facebook group calls this the estrogen kickback effect, where you seem to put in progesterone and it's not enough. All your estrogen symptoms intensify. You have sore, tender breasts, water retention, headaches. With progesterone, it might be 20, 30 milligrams, maybe 10 milligrams. I've even heard somebody had 2 milligrams the other day for something that's 1,000 times normally in the lowest part of its existence in the female cycle. We're using such tiny doses.
So what are your dose ranges that you recommend?
I like to definitely, well, it depends on symptomatology. So Dr. Jerry Lynn Pryor from the University of British Columbia, who has studied the menstrual cycle, and I'll give her website out because it's just chock full of information too. It's SEMCOR.
Where you can write it in the chat later. That would be the better way to do it.
Okay.
Yeah.
Yeah, she uses a minimum of oral progesterone, 300 milligrams, because she knows that this dose is needed to protect the bones. Progesterone stimulates new bone growth. So why are we suffering from osteoporosis when we know what can help us restore bones? Now we go into other dosage forms. Progesterone is absorbed differently with different dosage forms, creams, gels, suppositories, lozenges, injectable. All of these have different biochemical, pharmacological pathways and things that they produce results with. But bottom line for me is I want a woman to have enough progesterone to suit her needs. And a symptom that's really important with progesterone is there should be no anxiety, no sleep problems if your progesterone is adequate. And I'd like to tell a little bit my own history with fibrocystic breast disease, which I had for years, lots of mammograms, lots of breast pain. And I started when I was in my 40s at Women's International. I learned how important progesterone and estrogen is important for your skin structure. The collagen and the keratin are both dependent on these hormones. So I started using a little bit of that. And in 4 months, to my surprise, most of my breast lumps disappeared. And then just a little bit was left, and sort of a tribute to David too. I spoke with somebody else, so recommended adding a little iodine to that. Completely clear breast, and ever since then. So one of the things we're really missing the boat, back to David, we have to have healthy breasts. Let's have healthy breasts, and we have the means to keep them healthy. Why are women in this day and age suffering from fibrocystic breast disease or increased breast density? When you talk about going for mammograms, that should be gone. enough progesterone would make that gone, and we're not getting it.
I just want to make one comment. One of the places I think that it's malpractice, because I'm a breast cancer survivor, there are at least 70 to 100 studies where if a woman's going in for surgery, whether it's a lumpectomy, whether it's reconstruction, anything surrounding the milieu of breast cancer, if you can read nanograms per milliliter, at least 3 to 6 in the serum before she goes in, when they track women over the next 20 years, women who have pretty good progesterone levels in the blood before they go in for breast cancer surgery, they tend not to get a recurrence of breast cancer back. If they do get breast cancer again, they tend not to die from it. This has been replicated over and over again. Nobody translates this science. I wrote about it in Safe Hormones. It really is exasperating to me that we know this protection of progesterone and women are denied it.
In the UK, I have since learned that family practitioners in the UK can only prescribe 200 milligrams of oral progesterone. That's their only choice.
And here they
their
had
only
the home
strength.
of Katerina Dalton, and she would go up to
know.
900. Why is that?
Oh, she'd go higher than that. Minimum starting doses were like 400, 600 at a whack. So it's crazy. The mother of all this who identified PMS. If you check out PMS and you check out the massive number of symptoms associated with low progesterone that she identified, some of them pretty serious. Women having severe migraine, being suicidal, being homicidal. That's how serious these progesterone deficiencies could be, and all mediated or relieved by progesterone. She herself had seizures that were completely taken care of by her use of progesterone. And what are we? We're not looking at this basic scientific research, which is physiologically accurate, and it's so much safer to give doses of progesterone. And even if you go a little high, you're nowhere near the amount of progesterone that the human female body produces during pregnancy, in which the fetus, whether you're male or female, has access to these huge levels of progesterone during pregnancy. It is one of the most non-toxic things. And as we're talking about, if you don't have it, what are you going to get? You're going to get antidepressants, anti-anxiety agents, blood pressure drugs, sleep agents. Yes, all of those are things that progesterone should be doing for you, and it's not. So when I hear about such a restriction in the UK, I was totally shocked. In the US, we do some of that same restriction, but we do it by having big medical systems decide on what kind of protocols they're going to use or not use.
So what's the highest dose you've ever gone to? Because we're going to have to go to questions now. We're in the Q&A timing, but I'd like to know your higher end of dosing, Dr. Carol.
2,500 milligrams, might go higher.
But it's crazy that we have such controversy where hormones are dissed and pharmaceuticals are embraced, and women miss out and men miss out.
Mm-hmm. Totally. It's another whole story about men.
We've had a lot of people write in that they'd like us to do a conversation about men, but I just want to check in. We said the last half hour, and thank you so much for your commentary. I had 10, 15 questions pop in my head while you were talking. We need to go to some of the questions here. We wanted you to have your physicians that are on the fence, or they just started to take hormone replacement and got breast cancer and got scared themselves, or whatever situation they're in. We wanted to see if there's questions. And if we have questions, we'll have it. And if not, we'll keep chatting along. So please have some questions in the chat box. This is where they're going to be, right?
Oh, the Q&A, there's tons of them. 96.
Yes, there's 100. There's 100 questions here.
We'll be lucky to get through them all.
Okay, so I'm going to go to the top, and I'm just going to start going to a few. So here's one. So otherwise, I wouldn't have stopped you, Dr. Carol.
No
You were
problem.
great. Okay. Will there be time for questions? I was wondering about the situations with estrogen will be combined or with progesterone, or should it be modified in their percentages of prescription? So in other words, if you have the BRCA gene, if you have the genetic glitch, the BRCA gene glitch makes you more at risk of all cancers, not just breast cancer. What about replacing estrogen and progesterone in women who have the BRCA gene polymorphisms? Anyone want to answer that?
Yeah, I mean, and I'd love to hear Dr. Brownstein's and Rosensweet's thoughts, but typically in those patients, I'm always pretty comfortable with, and actually in most patients with breast cancer, with testosterone right out of the gate. I think that that's a really helpful hormone. The data is very, very reassuring, although it's not been studied frankly at all in BRCA patients, but the other data in generalized breast cancer is very, very reassuring and actually very compelling. So in these types of patients, generally I would start testosterone plus minus an aromatase inhibitor, depending on the clinical scenario. And also,
now, do you give a pharmaceutical aromatase inhibitor, or do you use something like melatonin and grapeseed extract?
Well,
and progesterone is an aromatase inhibitor.
Yep.
Yes, it is. Yes, it is. So I would generally use a vaginal estrogen, estradiol or estriol specifically. I think in those cases, I would not be inclined to start progesterone, but I know Dr. Petersen would probably not agree with that.
Okay, and I'm going to go on to some of the other questions because we've got so many. And by the way, I have a little book called Hormones for Breast Cancer Survivors, which up till the date that it was written, it summarizes Dr. Rebecca Glasser and Demetra Kakis's work on the use of testosterone in breast cancer patients. And I have a chapter on BRCA gene patients in the research giving hormone replacement. And estrogen has been very helpful in those patients, and yet women are getting oophorectomies and mastectomies, et cetera, when a lot of that is, you can hear how questionable that is by our conversation. Next question, what are your thoughts on double mastectomy? There you go, for the BRCA gene. So can you please talk about that? Would you recommend double mastectomy if someone came in and had that genetic glitch?
Just because you have the genotype doesn't mean you have to have the phenotype. Doesn't mean it has to express itself. So, I think, look, I'll take the safe answer here. Every woman should decide. I tell my patients, look, here's the pros and cons, and you can decide your own. But I think that eating a good diet, exercising, getting sugar out of your diet, correcting nutrient deficiencies like iodine should be the first course for these women before they're opting to just. I mean, look, they get these tests. They have a BRCA mutation. Man, they're going for oophorectomy, mastectomy, and hysterectomy, right off the bat without even being told anything about anything else. And I certainly don't think that's the right course.
I agree with you, David. I think it's really dependent on the patient because, some people are going to have a lot more anxiety over things of that nature, and also maybe limited availability for screenings and additional testing and imaging to protect themselves.
These polymorphisms, though, give you a higher risk of stomach cancer, pancreatic cancer. You can't you can't do a whole body ectomy. So, it's not just about your breast. So it really is about doing other things. And it's crazy that there is research that when these women go on estrogen replacement, they have less risk of getting breast cancer. So it's not what we've been told. And unfortunately, the myth is being taught in med schools. And then when patients ask their doctors, they're not getting these answers. So I love that we're on here. The next one is, can you suggest a good hormone doc in New York City? I would call up Dr. Leo Galland and ask him if he could recommend one. He's a really good colleague of mine. I don't know if you know somebody.
Erica Schwartz is a friend of mine who's in New York City, and she certainly knows bioidentical hormones.
Yeah. And if any of the people on this you can reach out to Belmar Pharma Solutions, and we have a good group of pharmacists and references and resources that can direct folks to good folks in their states too. So
excellent.
And our website is posted, and we've trained doctors all over the country, including in New York State. And we have a few that do our method in New York City.
So your method is called the menopause method. We're going to give everybody's links so that your books, your links and coupons with the doctors who've sent coupons, and Dr. David Brownstein and myself are giving a 2-day online course in everything hormones. How do you test them? How do you prescribe them? What are the bases? And how do you track them Monday morning ready? Because we felt the need for this. So we're going to have a coupon ourselves if you purchase that by the end of midnight. So we have a number of goodies for you at the end of of this talk. I should have said that in the beginning, but I'm saying it now. And on to the next question. I was placed on bioidentical hormones after the birth of my daughter as my hormones plummeted at age 39 and I'm 54 now. Is there any risk in continuing these for as long as I require them into my 60s and 70s and beyond?
Lindsey, you should answer that one.
David, you should never give away a woman's age. What are you thinking?
Well, no, I don't mind
Thank you,
screaming.
Larry.
I'm really proud and grateful that I'm 75 and kayaking on a cardio run with women 20, 30 years younger than me on the weekends. But it's really crazy, this estrogen window thing, that if you didn't go on hormones by the time you're in your 60s or 70s, you've missed out and you're going to have worse heart disease. You know, those studies that show that older women do worse on hormones, again, those were with progestins and with pregnant conjugated equine estrogen. You have to look at what those were. So we initiate hormone replacement in women in their 90s. You just have to do it slower because the satellite dishes have been sleeping. And the first year that you add hormone, they're a little hyper as they wake up. So a great doc just goes slower to do Sleeping Beauty, wake up better, but it's never too late to start hormones. That is an inappropriate myth that once again gets women to miss out. So a great question. Next question. If we are ordering bioidentical hormones from a compounding pharmacy, Carol, I think you should do this one. How do we know our formula is bioidentical and doesn't contain additives? And maybe Dr. Rosensweet, you can talk on that after Dr. Carol says something. Okay.
Well, actually, compounding pharmacies, there's been like a propaganda war, I think, coming from pharma, like insinuating that something is less than. I'd like to reassure people, and this comes under FDA rules and regulations. They are in charge of all drug products, all drug substances used in the United States. They have certain standards of quality and safetiness. Well, not safety unless you've been FDA approved. Only FDA can say that. But the quality of the raw materials has to be there, or the FDA can seize it, whether it's compounded, manufactured, or even
And
over
just
the
to keep
counter.
you going short, because we got so many questions, so I
Go
want
ahead.
your answer, but I just want you to be okay.
So the hormone is a hormone is a hormone. If somebody is crooked and they mislabel it and put something else in there, that's an issue. They're crooked, but they're legally required to be accurate and use the hormones that are on the label.
I don't know that there's an industry more regulated than compounding pharmacists. And because I've worked with compounding pharmacists so long, I hear stories of being swooped down upon and the FDA spending a long time. And so I feel tremendously reassured, and all the compounding pharmacists I've known are really good scientists. They love it. This is what they care about. They're more interested in working with individualization. And there's some just wonderful people in the compounding pharmacy world. The other thing is estrogen and testosterone are best delivered transdermally or through a mucosal surface. And when you see gels and creams on the market, they're strong solvents. So best case scenario is to have an organic oils base that these hormones are delivered in. And I think that matters. We don't want to continue to deliver toxicity to women, but in general, my goodness, hormone treatment in the offices of those who really care about it, have done some studying, are doing good work. Almost any hormone you can name, if managed properly, is going to be very beneficial for women and men. How long? It was a total myth. Take the smallest dose for the shortest period of time. Someone made that up.
So that is what's taught a lot at most of these hormone classes. Start low, which we do want to do, start low, but then it's take the shortest amount for the shortest period of time. That is a terrible myth that does not serve women and men. But I want to get to the next question. Sorry, we could go here for the next 5 hours. I'm going to be like a little maternal here and keep us going. What about see my age? I think I'm no, I'm not. Okay. I'm not going to say anything. What about the dirty estrogen, increased accumulation of estrone metabolites when you add more estrogen? How does this not increase even more? Thanks for your insight, Phil from Santa Fe.
Iodine helps with that. And iodine helps to keep the metabolites pushed more towards the estriol side and away from the
Exactly.
estrone side.
And so does
I
DIM.
just saw
Yep.
well, DIM maybe, but not in a low estrogen woman. You're not going to be able to use it. 16 alpha hydroxy pathway is pushed in a hypothyroid situation, which iodine in turn helps.
I actually created products based on helping me want to continue to take hormones safely, but I'm not going to even go there now. But it's all about maintaining these proper pathways. Next question, when estrogen is given to a peri or postmenopausal woman who has fibroids and or endometriosis, how can intermittent breakthrough bleeding be handled?
I think in those cases, it's important that those are obviously going to be stimulated by estradiol if it's given. So in those cases, starting very, very low on doses and then managing with progesterone if need be. But sometimes those patients, the fibroids are so large that the only solutions are either to not use estrogens or estradiol specifically, or have them surgically removed in some manner, either myomectomy or hysterectomy. But in those patients, I always find that testosterone is really a great product to use because it doesn't stimulate those fibroids. And you can either start with no estrogen in those patients because testosterone is going to have a little bit of conversion to estradiol in the system, which can help with some of the estradiol deficiency in the body. But I find that some women, if I can just keep the doses low enough that I can use them, but avoid some of the breakthrough bleeding. But in some cases, that those fibroids are just going to be brutal, and we have to make some hard decisions then.
I don't know how you guys feel, but I do a lot with vaginal delivery. I use the MBK soft pellets and I do the vaginal first pass. And that has been, if they're small enough fibroids, small enough, that's been very helpful for that to deliver it right up into the uterus rather than looking at putting it in the body another way and hoping it's really getting there. That's just a thought. But actually, this next person asking this question is a girlfriend of mine that I love and adore. And here she is with a question. I'm not necessarily going to say her name, but the most difficult question I'm asked in practice, she's an amazing nurse practitioner. The most difficult question I'm asked in practice is from breast cancer survivors asking if they can safely use BHRT, particularly ER/PR positive breast cancer. So I know that David Rosensweet might want to make a comment on ER positive or somebody. This is a great. So she's asking, what about the safety in breast cancer survivors, especially if they've got ER positive identifiers on their tumor?
ER positive is not an indication to not administer estrogen, because as Dr. Blooming has pointed out, in any estrogen, breast cancer that's removed from a breast, for example, there's all kinds of cells in there. And the cells that are ER positive are pretty well differentiated, and they're not the problem. It's the ones that are cancer cells that are super undifferentiated that are the real problem. The literature says that ER positive does not matter. This is not the defining factor. Things matter, but in general, the statement that you can make for a woman who's had breast cancer and had that breast cancer properly treated, that she's at less risk of recurrence if she's treated with hormones. And this was discovered before the ER positive and progesterone positive cells were discovered. So there's a very gray area here, but the science is best saying this is not going to be a problem. These women can also be treated with estrogen and progesterone.
Before tamoxifen, before Craig Jordan put tamoxifen on the map, metastatic breast cancer was treated with 6 milligrams of estradiol. Because when you go, hormones are not like carcinogens. They downregulate the system when you go high. And they used to use estrogen to treat metastatic breast cancer. But all breast tissue has ER positive, PR positive. We're not sure that that's really the way that hormones are driven, as much as cancer stem cells that don't have hormone receptors on them. But that's really a big commentary. But iodine that Dr. Brownstein was talking about is so important. And that's why Biest or estriol, adding that second estrogen that signals the anti-cancer second receptor, estrogen receptor beta signal, is so important. Yet none of that is discussed in most of the over-the-counter most of the regular pharmaceutical estrogens do not contain estriol. And the pellets don't contain estriol. Do you add estriol when you give a woman a pellet? You don't?
I don't.
Because you think that the testosterone, the third metabolite, signals that second estrogen receptor. Is that why?
I'm a huge fan of pellet placement, and I agree with Dr. Rosensweet that transdermal preparations, anything that goes non-oral, is going to be more effective and have a greater applicable and greater good in the body itself. But I have not felt the need, especially if I have doing estradiol pellets coupled with the testosterone, which I think is even more important than the estriol for the breast overall. But I know there's lots of folks who would disagree with me, but I just don't feel the need to add that third complexity to the puzzle, especially when I'm doing progesterone, estradiol, and testosterone.
That's why it's good to hear everybody with their own commentary. How would you handle low estrogen but high progesterone? That's a rare situation.
How often do you see that?
Yeah,
I don't ever see that.
Never.
And okay, that was a nurse practitioner asking that. Next question, is bioidentical progesterone always synthesized from wild yam? What are the differences between, so Carol, I don't know if you want to tackle this. What are the differences between progesterone hormones prescribed from the pharmacy versus compounded pharmacy, and HRT, which form of estrogen, estrone, estradiol, estriol, is being used?
So it was first synthesized by Russell Marker in the 1940s from Mexican wild yam. John Lee has in his book like 2,000 different other plants, maybe even more, could have been used in this manufacturing process. So soy is often used. The two biggest raw materials are soy and the yam. And basically, you extract a cholesterol-like molecule from the plant source, and then you convert it synthetically to whatever hormone you want. This is how you make the bioidentical ones. This is how you make most of the synthetic ones as well.
This is David Brownstein. I want you to answer this question. So Dr. Morgenthaler, when he and I both spoke in Miami, and he's on the same mission with men that we all are with women, or we are with both genders. Why would Mother Nature make the very hormone that drives humanity be pro-carcinogenic? It makes no sense. So this question is right along this line, and I would like to hear Dr. Brownstein's answer. So why would nature have us lose estrogen, hormones, et cetera, if it's so protective as we age?
Hello, Dr. White. So I think it's Mother Nature's way of saying you're old enough, your kids should be able to take care of themselves, and natural selection comes into play, and move on. And I think that's why those levels fall off, and that's what caused, chicken or egg, is aging cause that, or does that cause aging? But I think it's a combination of both a little bit. But I certainly can tell you from 30 years of doing this work and from taking these hormones myself, you can certainly age a lot more gracefully and live a lot more productive life to keep your hormones balanced through old age.
And to add on to that, my patients often ask me this, and even doctors ask me all the time, well, why are we giving hormones when the ovary shuts down? Well, Mother Nature never intended us to have children to past 50, God forbid, and their children would not survive us, or often we would pass before the children reached adulthood, and especially back in the day. And unfortunately, it's an unintended consequence that does present the fact of natural selection and rapid aging for women, but we're not going quietly into the night anymore.
Well, I can't see without glasses, but I go ahead and purchase these glasses, and I'm, wearing them to improve my vision. So we have better living through chemistry and technology these days. So we're slowing down aging. That is natural aging, but we've learned that we can stay younger longer with some replacement of hormones, as well as exercise, diet, your poop-tutionals, regular poop, everything adds up. Next question. Did all of the patients in the estrogen-only arm of the WHI study all have hysterectomies? If so, how do we know the hysterectomy itself doesn't account for the lower risk of breast cancer?
I think we're looking under the wrong lamppost for what causes cancer. Cancer is a very serious illness, and it has causes. And they come down to the basics, like how are you damaging the human body? We're genetically programmed to be very healthy folks. But if we do things that are really detrimental to us, we're not eating right, we're not breathing right, we're exposed to toxins. Devaki, you've written beautifully on this. We have an exaggerated biological response to stress. This is where we ought to be looking for the causes of illness. And there's thousands and thousands of adverse events that humans do to ourselves over the course of a lifetime from being in the womb. We're putting all our attention on hormones cause cancer or hormones don't cause cancer. And it's totally unclear. The evidence really comes down, no, they don't. But there are causes of cancer. And as David was suggesting, we really want to address what it takes to be healthy and be strong. And what do the hormones do? They strengthen us. They strengthen our immune system. Who did well in COVID? Women who had good, healthy hormones, and men do. The final thing I'd like to say is, why don't you interview the folks who've been on hormones for a long time, like Lindsey and like David and like myself and Carol and Angela, and you ask somebody, do you think you should take the smallest dose for the shortest period of time? And I'm telling you, I'm going to be taking this every day I'm on the planet. Someone try and take this away from me, which is my testosterone, and talk to any woman who's had the benefit or any man who's had the benefit of really good hormone treatment. They'll tell you what's done for their health, and you are not going to be able to remove, unless forcibly, the hormones that they take every day.
One of my favorite comments was when I was working with Dr. Richard Wiseman at the Wiseman Family Practice, and he was running Ironman in his 70s and had been on testosterone replacement for years. And he would say, if you took 100 people and everybody got the memo to exercise and eat right, but 50 of those people were on hormone replacement. They had balanced hormones. They'd been on hormones for a while. You could cherry pick them out. You could see shinier hair. You could see better projection, vocality, because you got hormone receptors on your vocal cords. They'd stand up straighter. They wouldn't have to pee as much at night when they get up because they have better filtering out of their kidneys. You could tell because people on hormone replacement, and that's really the problem. But when I worked at Tulane as a distinguished hormone scholar at the Center for Bioenvironmental Research, we would always talk about two major theories of cancer. There's the DNA damage driven by hormones. That's a theory. And then there's cancer stem cells, which everybody knows cause recurrence and metastases, but now they're being looked at, especially by Avram Blooming, as more driving, initiating, and they have nothing to do with hormones. And nobody talks about, so the Women's Health Initiative stopped basically most prescriptions July 2000. Up until then, there were 26 studies where they took women with ER positive, PR positive breast cancer and gave them estrogen. Some of the studies went 30 years, some went 24 years. I lectured for the International College of Integrative Medicine, ICIM, in Dearborn in 2022 with David's group, going over all of these studies. And not one study did the ER positive breast cancer patients fare worse. And some of these studies were run by MD Anderson, University of Wisconsin, University of Georgia. Just a few of the studies were off mainland. We never talk about those studies. We invited some of the people that have a little bit of a different point of view. And I literally sent this doctor that I'm thinking about, whose name I don't want to mention names here, all of those studies, and we didn't hear anything back from that. They gave hormones in 26 studies to ER positive breast cancer patients. And if ER positive is the big deal, then why do we deny hormone replacement to triple negative breast cancer patients? Why can't they just get hormones right out of the chute? There's all these questions that patients are missing out on. We've got one more question. And then I've got to do housekeeping of closing everything up. This has been so amazing. Do I want to take estriol or estradiol or a combination of both, and why? And who would like to deal with that? And then I'm going to close up. That's our last question. That's all we've got time for, unfortunately.
Take estriol and do it in combination with estradiol. That's how young women who have cancer have less estriol, and estriol inspires the receptor sites in the breast that deproliferate cells. Every single menstrual month, a woman builds up her breast glandular cells in preparation for possible lactation. And every month, if she does not get pregnant, they disappear by apoptosis. And what inspires that? Estriol. And the studies that show what normal healthy women have is they have too much, almost 2 times as much estriol as they have the sum of estradiol and estriol. So as Jonathan Wright suggests, why invent a new human being? Why not copy nature and copy the nature of the young, healthy women who don't have breast cancer. Estriol, yes.
So when
Agreed.
I was at Tulane, I'm sorry, did you want to say something, Dr. Brownstein?
Agreed.
He agreed. When I was at Tulane, I worked with Yanaki Gustafsson. He discovered the second estrogen receptor that estriol signals. When he came out with that paper, it had the justice scales on it because he said that the balance between ER alpha and ER beta dictates the health of local tissue. That's what it's all about. And so he started looking at botanicals that signal ER beta. And he looked at milk thistle. He looked at apigenin that comes especially from organic parsley and celery. And also he looked at oatmeal, and he looked at a variety of things, and he was able to show that they could treat breast cancer, that the signals, that estriol signals were so powerful, it was a treatment for breast cancer. He got wooed over to a pharmaceutical company. He's from the Karolinska Institute. He's very tall. He would put on so he came to Texas, put on a big cowboy hat with a thick Swedish accent, and is working for a pharmaceutical company to make a pharmaceutical that acts just like apigenin, botanical, milk thistle, estriol, and the third metabolite of testosterone to signal estriol as an anti-cancer drug. So these things literally work. And the functional doctor looks at this bigger picture and your bigger picture to try to put this all together to help you out rather than to just fit you into a conveyor belt of pharmaceuticals and make you feel a learned helplessness. I got to tell you, I love you guys. Each of you,
Me too.
what a great group. We could talk for the next 2 hours. So we're ending now and we're going to just tie it up, but I want to go through each member and have you at least make a closing remark of what you would like to say about this conversation that we've all been sharing.
I guess I'll start. First and foremost, as for the patients out there, trust your bodies, trust your instincts. If something doesn't feel right, keep searching for the answers because everything you're being told may not necessarily be truthful. And it's important that you advocate for yourself and learn all that you can and get it from really good resources and don't just expect your traditional doctors to have all the answers. And to the physicians out there, I just really encourage you to really look at the data and don't just say there is no data. There's a plethora of data. You just have to be willing to go look at it and read it and study it and take that time. It's well worth it.
Dr. Carol?
I really want to encourage everybody to look at progesterone really seriously. It's the first hormone to drop. It's the first one you should pay attention to. All these hormones are wonderful. They spell better quality of life, probably lengthier life, but we won't know for hundreds of years probably. And it's such a wonderful tool that we have for the first time in human history.
David Rosensweet.
As you age, you're going to want to be healthy and vital, maybe even have libido, maybe even have sexual relations. You're going to want to walk and talk and think clearly. And by far, although there's so many things that contribute to that health, by far, the taking of hormones and doing it right, you're going to love it and you're going to be so grateful for it. And it's going to put you at less risk for breast cancer, heart attack, and stroke, or prostate cancer if you're a male, if proper hormone treatment is being done. Embrace them. They're the manna from heaven.
David Brownstein, one of my peas in a pod.
Well, I would say don't settle for substandard care and substandard not feeling well symptoms. That if you're not getting what you want from your healthcare provider, time to find a new one. There's lots of holistic doctors out there who think like we do. And, the only way the system's going to change is when when the money shifts to that and the business shifts to that. And, this is not about money because those of us that went into it know the stress and the regulatory agencies coming after us and, what we put into it. But, we're going to have to shift those healthcare dollars. 20% of our GMP a lot of it goes to garbage. And if you're not feeling well, you're not getting the care you need, it's time to look around somewhere else. And don't settle for substandard care.
I love that. I love that. Demand better care. So what we have here in the chat is Dr. DeRosa's. We have all the doctors, their coupons, their information, which we will also send out to you again with the link, the recorded link when this is edited. And Dr. Brownstein and I have been very frustrated at the level of teaching that's gone on to create better hormone practitioners that are based in science. So we decided to do a 2-day online course. It's going to be April 26th, a Friday, April 27th, a Saturday. So it's 16 hours of CMEs for MDs, nurse practitioners, nurses, PAs, and naturopaths. If you want to sign up for that, we have a coupon if you purchase it by midnight tonight for $100 off. So please take a look at all of this information right along here. There's Dr. Rosensweet's information, and we're also going to have Dr. Brownstein, because he doesn't sell his books on Amazon, like Dr. Gavey doesn't sell his books on Amazon. People got upset nutritional medicine wasn't on Amazon. Dr. Brownstein's books are all at his website. So we will have all of those links so that you can have access. This is not only 150 years combined of doctors having experience with writing scripts for hormones. These are doctors who write books, doctors who teach, doctors who have programs, pharmacist who has worked in the trenches with the compounding, the bases, the feedback from doctors and patients alike. This is truly exceptional, and they all have a lot of material. So please take time to look at this on this list. Plus, we will send it to you again. And we're going to also take this link and republish the recording in Substack, on Rumble, on YouTube. We're going to really put it around so that we can try and make a difference among practitioners and patients and really help pass the hormonal word. So don't forget to really look at this all well. Let's see, it goes down here. Here's the CME link and coupon code again. The coupon is good for today only till midnight, and it's called Everything Hormones with Dr. Brownstein and myself online the last Friday and Saturday of April. Then we've got Dr. DeRosa's information, and then we've got Dr. Carol's information. And I'd also like the doctors to take a look at this when you go home and make sure that we're not missing anything that you'd like to get out to people, because there's probably going to be about 10, 15,000 people over the next 2-3 months that look at all of this. So we don't want to lose this opportunity for people to understand your work. And then we've got Dr. Rosensweet, the menopause method, and he's got a book out called Happy Healthy Hormones. And then I've got some books out, but I'm not pushing those books. Here's Dr. Brownstein's books. He's got a whole plethora of books, and he was really smart to make them all look very similar in color. He planned way ahead when he put those covers together. I didn't do that. You had it together. So you all were seeing patients all day, and then you came here to come together and really help patients and physicians. I can't thank you enough. I would not be who I am today, missing so many organs. If I wasn't on hormone replacement, I wouldn't have the cognition and the energy and the lucidity to be part of this tribal community. So thank you so much for being here. And everybody, thank you for taking your time for being here. We hope you'll make use of all of these links. And Dr. Brownstein and I hope that we get to see you on our talk. And then Dr. Rosensweet and I have some exciting things planned for the fall. So there's lots coming down the pike. Please keep in touch with all of our websites, because we're here to help pass this word forward. Nobody here was getting paid to do this. This is not about bucks. It's about passing the information forward. So blessings, everyone. And thanks again, all of you, for doing this, and everyone else who attended.
Thank you, Lindsey, for hosting. We really appreciate you.
Bye, gang. Much love. Much love.